Hello and welcome to this session. In this session, we'll be looking at perioperative nursing. Okay, perioperative nursing. So, welcome to this session. We hope it will be helpful for all of us. So, perioperative nursing involves the care of patients before, that is preoperative, during, intraoperative, and after surgery, that is postoperative. So, if you are a perioperative nurse, of course, you should know that you are a crucial member of the surgical team and your role is to ensure safety, comfort, and well being of the patients throughout the entire surgical process. Your responsibility will vary, ranging from tasks related to the patient care, surgery preparation, and assisting the surgical team in post operative recovery. When you look at the first phase, which involves the pre-operative phase, this phase will include three major roles: assessment, education, and preparation. And in assessment, you're supposed to know that perioperative nurses will assess patients' overall health, medical history, and medical conditions, just to identify potential risks and develop individualized care plans for their patients. In terms of education, you'll educate patients about surgical procedure, what to expect before, during, and after the surgery, and provide instructions on pre-operative preparation such as fasting and medication management. On preparation, you as a perioperative nurse, you're going to ensure that the operating room is properly set up, including sterilization equipment, checking of the surgical equipments, and verifying the accuracy of the patient records and their consent forms in that particular manner. So let's start by obtaining the informed consent. First of all, we have to know that the surgeon is the one who is normally responsible to explain the surgical procedure to the patient and answer any patient's concerns. Okay, so this involves any questions relating to the procedure and maybe probable the after the procedure, the way maybe is going to recover. The surgeon has to get the answer to that. Often we see the nurse who may be responsible to obtaining the client's signature on the consent form of the surgery, which indicates that the client agrees with the procedure based on the surgeon's explanation. Sometimes the nurse may witness the client signing of the consent form, yeah, but the nurse must be sure that the client has understood the surgeon's explanation of the surgery. The nurse needs also to document the witnessing of the signing of the consent form after the client acknowledges understanding of the procedure. If you have a minor, these are clients who are normally younger than 18 years. In this case, you may need a parent or the legal guardian to sign the consent form. For the older patients, they may need legal guardian to sign the consent form. And psychiatric clients, of course, we are saying that we have to know that they have a right to refuse treatment until a court has legally determined that they are unable to make decisions for themselves. Remember that no sedation should be administered to a client before they sign the consent. They sign the consent before the sedation. Obtaining a telephone consent from a legal guardian or the power of attorney for the healthcare is acceptable practice if the client are unable to give the consent themselves. The nurse must engage another nurse as a witness to the consent given over the phone. In terms of nutrition, you are saying that you need to review the surgeon's prescription regarding the nil per oral or nothing per mouth status before surgery. You need to withhold foods, solid foods, and liquids as prescribed to avoid aspiration, especially for that's usually around 6 to 8 hours before general anesthesia, or approximately 3 hours before surgery with the local anesthesia. You also need to insert an intravenous line, administer IV fluids if prescribed. The IV size, remember, should be large enough to be able to administer blood products if they are required. On elimination, if the client is to have intestinal or abdominal surgery per the surgeon's preference, an anemia or a laxative or both may be prescribed for the day and night before the surgery. So the client should void immediately before the surgery, and then you insert an indwelling catheter if it's prescribed. Urinary catheter collection bag should be emptied immediately before surgery, and the nurse should document the amount and the characteristics of the urine. In terms of the surgical site, you need to clean the surgical site with a mild antiseptic or antibacterial soap on the night before the surgery. You need to shave the operative site as prescribed. Shaving may also be done in the operative area. Okay, so you really need to know what's the policy for your facility. The test point could include, guys, you're saying that hair on the head or the face, including the eyebrows, should be shaved only if prescribed. Okay, yeah. Preoperative client teaching, you need to inform the client about what to expect post-operatively. You need to inform the client to notify the nurse if the client experiences any pain post-operatively, and the pain medication will be prescribed and given as the client requests. The client should be informed that some degree of pain should be expected, and this is a normal finding. Inform the client that requesting an opioid after surgery will not make the client a drug addict. So some patients will fear to ask an opioid, fearing that they may develop addiction. So this should not be a concern. You also need to demonstrate the use of the patient control analgesia pump if prescribed. Then you instruct the client how to use non-invasive pain relief measures. These measures could include relaxation, distraction techniques, guided imagery before the pain occurs and soon as the pain is noticed. The nurse should also instruct the client not to smoke. That is for at least 24 hours before surgery. Okay, we said nil per oral, nothing by mouth. Okay, discuss smoke cessation treatment and programs with the patient. You instruct the patient in deep breathing and coughing techniques, use of incentive spirometry, and the importance of performing the techniques post-operatively to prevent the development of pneumonia and atelectasis. You also need to instruct the client in leg and foot exercises, and this will prevent venous stasis of blood and facilitate venous blood return. You also need to instruct the client on how to splint an incision and turn and reposition. Inform the client about any invasive devices that may be needed after surgery, such as a nasogastric drain, urinary catheter, epidural catheter, or IV or subclavian lines. Lastly, you need to instruct the client not to pull on any of the invasive devices. They will be removed as soon as possible, and the patient should need to cooperate. In terms of psychological preparation, you need to be alert to the patient level of anxiety. Okay, as an RN, you have to answer any questions or concerns that the patient may have regarding surgery. Remember, the initial teaching is normally done by the surgeon. The RN reinforces the information. Allow time for privacy for the client to prepare psychologically for the surgery, and provide support and assistance as needed. You need also to take cultural aspect into consideration when providing this care, so that you're providing culture sensitive care to our patients. For the pre-operative checklist, to ensure that the patient is wearing an identification bracelet. You assess the patient for any allergies, including allergy to latex. Review the preoperative checklist just to be sure that each item is addressed before the client is transported to the surgery. You follow the agency's policies regarding preoperative procedures, including informed consents, preoperative checklists, prescribed laboratory or radiological test, and any other preoperative procedure. Ensure that informed consent forms have been signed for the operative procedure. Any blood transfusion, disposal of a limb, or surgical sterilization procedures lists are included. Ensure that the history and physical examination has been completed and documented in the patient's record. Ensure that the consultation requests have been completed and also documented in the client's record. Ensure that prescribed laboratory results have been documented in the client's record. Looking at also the electrocardiogram and chest radiography reports are also included. Ensure that a blood type, screen, and cross-match are performed and documented in the client's records within the established time frame as per the hospital's policy. Remove all the jewelry, makeup, dentures, hairpins, nail polish, glasses, and prosthesis. You document that these valuables have either been given to the client's family members or they have been locked in a hospital safe. You document the last time the client ate or drank, and document that the client voided before the surgery. Document that the prescribed preoperative medications were given. Monitor and document the client's vital signs. You also need to administer the preoperative medication as prescribed before surgery. Instruct the client about the desired effects of these preoperative medications. Remember, after administering any preoperative medications, you keep the client in bed with the side rails, and based on the facilities guidelines, you also need to place a bell, call bell next to the client. Instruct the client not to get out of the bed and to call for assistance if needed. These are just some of the interventions that help us to reduce the incidence of falls in the hospitals. So from pre-operative, we can now go to the intraoperative phase. An intraoperative phase has four major uh, roles that we as nurses we need to perform. One is assisting the surgeon during the operation, maintaining sterility, monitoring, and advocacy. So in assisting the surgeon, you need to assist the surgeon by providing the necessary instruments and supplies during the surgery. In maintaining the sterility, it's responsibility to ensure that you maintain a sterile environment in the operating room, ensuring that all members adhere to the strict infection control protocols. And this is majorly to minimize, avoid, prevent all the kind of infections. You also need on monitoring, you as a perioperative nurse, you need to monitor the patient's vital signs, analgesia administration, and the overall well-being of the patient during the operation. As an advocate, you also need to perform advocacy for your patients, ensuring that their safety and comfort throughout the surgical procedure. So, upon arrival in the operating room, you need to come up with some guidelines to prevent the issue or the issue of wrong site, wrong procedure, guys. Guys, I hope you have ever had a situation whereby someone was performed a wrong procedure, guys. Okay. Yes, so the surgeon should meet the patient in the preoperative area and use indelible ink to mark the operative site. So in the operative room, the nurse or the surgeon should ensure and confirm that the operative site has been appropriately marked within the indelible ink. Just before starting the procedure also, you need to perform a timeout, okay, with all members of the operative team, just to identify the correct client and appropriate surgical team again. Ensure that when the client arrives in the operating room nurse should verify the bracelet with the client's verbal response and will review the client's charts. The client's record will be checked for completeness, reviewed for informed consent forms, history, and physical examination and allergic reactions information. The surgeon also prescription will be verified and implemented. The IV line may be initiated at this time. Then the analgesia team will administer the prescribed analgesia. Remember, at this point, it is about verification of the client and the surgical operation site. This is very crucial to ensure that we prevent wrong site and wrong surgery. In the post-operative phase, we have four major roles as RNs. We have to promote recovery, we have to do wound care, we have to perform the patient education and do some follow-up. On recovery, we as perioperative nurses, we need to monitor the patients closely as they recover from the analgesia, and we assess their response to surgery and manage the pain in order to improve their comfort. In terms of wound care, we have to oversee the wounds, okay, ensure that incisions are clean and properly dressed to prevent infection. Guys, a link will be popping up on the wound care and types of wound healing and how that happens. Next, we have patient education as an RN. We need to educate our patients and families about the post-operative care, including the medication management, activity restrictions, and any signs of the complication thereafter, so that the patient could report on time. Also, on follow-up, we need to provide follow-up care. We need to monitor the patient's progress and collaborate with other healthcare professionals to ensure a smooth transition to the next phase of recovery. So, what is post-operative care? This is the management of care of a client after surgery, and it includes care given during the immediate postoperative period as well as during the days following surgery. The goal of postoperative care is to prevent complication. You want to promote healing of the surgical incision, and you want to return the patient to a healthy state. So we start by looking at the respiratory system. Okay, you ensure that you assess the breath sounds. Stridor, wheezing, or crowning sound can indicate partial obstruction or bronchospasms or laryngospasms, while cracos or rhonchi may indicate pulmonary edema, of which all are serious complications that have to be given the necessary attention. We need to also monitor a few things. We need to monitor the air patency and ensure adequate ventilation. Remember, prolonged mechanical ventilation during anesthesia may affect the post-operative lung function. So, also know that extubated patients who are very lethargic may not be able to maintain the airway. So you monitor for secretions. If the patient is unable to clear the airway by coughing, you need to suction the secretion from the client's airway. You need to observe the chest movement for symmetry and use of accessory muscles. Also need to monitor the oxygen administration if prescribed, monitor the pulse oximetry, encourage this patient to have to do or perform deep breathing and coughing exercise as soon as possible after the surgery. You note the rate, depth, and quality of respiration. Remember, the respiration rate should be greater than 10 but less than 30 breaths per minute. Of course, the normal rate is 12 to 20 breaths per minute, but this is the normal range. This is the ranges that we have for this kind of patients. Okay, it should not be below 10 and it should not be more than 30. That should be the range. So you need to monitor signs for respiratory distress, atelectasis, and other respiratory complications. On cardiovascular system, you need to monitor cardiovascular status, such as the skin color, peripheral pulses, capillary refill, and for the absence of edema, numbness, and tingling. You also need to monitor for bleeding. Okay, signs could include like somebody who is swallowing something, somebody who is having epistaxis, and other who may be having the GIT bleeding. Also need to assess for the pulse rate and rhythm. Remember, a bounding pulse may indicate hypertension, fluid overload, or client anxiety. You also need to monitor for signs of hypertension, hypotension. Also monitor for the cardiac dysrhythmias. Remember to monitor for the signs of thromboblitis, particularly in patients who have been in lithotomy position during surgery. Guys, a link will be popping out on how to position a patient in lithotomy, and you can be able to observe and appreciate why and how thromboblitis normally develop. You also need to encourage the use of anti-embolism stockings or sequential compression devices if prescribed. This is just to promote venous return, to strengthen the muscle tone, and prevent pooling of blood in the extremities. On the musculoskeletal system, the nurse needs to assess the client for the movement of the extremities. You need to review the surgeon's prescription regarding client's positioning or restrictions. Encourage this patient so that you have early ambulation if prescribed. Also instruct the client to sit at the edge of the bed with his or her feet supported to assume balance first before they can raise up. Unless contraindicated, you need to place these patients in a low Fowler's position after surgery to increase the size of the thorax for the lung expansion. Guys, a link will be popping up on how to place the patients on the low Fowler's position. Remember, you need to avoid positioning the postoperative client in supine position until these pharyngeal reflexes have returned. If the client is comatose or semi-comatose, you position this on the side, okay? If the client is unable to get out of the bed, you need to turn the patient after every 1 to 2 hours. What about neurological system? The nurse needs to assess the level of consciousness, time, place, person. Make frequent periodic attempts to awaken the patient until the client awakens. You orient the patient to the environment. You speak in a soft tone. You filter out any extraneous noises in the environment. Maintain the patient's body temperature and prevent heat loss by providing the client with warm blankets and raising the room with the room temperature as necessary. You ensure that you monitor the temperature, you monitor the signs for hypothermia that may result from anesthesia. Remember, a cool operating room. Also, exposure of the skin or internal organs during the surgery could result in hypothermia. So you need to apply warm blankets, continue oxygen, and administer medication as prescribed if the patient is experiencing postoperative shivering. On the integumentary system, the nurse needs to assess the surgical site, the drain, and the wound dressings. Remember, serous drainage may occur from an incision, but you need to notify the surgeon if excessive bleeding occurs from the site. The nurse needs to assess the skin for redness, abrasions, or breakdown that may have resulted from surgical positioning. You need to monitor the body temperature and wound for the signs of infection. Maintain a dry, intact dressing. You need to change the dressing as prescribed, noting the amount of dressings or drainage, order, or intactness of these sutures or staples. Commonly used dressing could include the inch gauze, the non-adherent pads, the abdominal pads, the gauze rolls, and the split gauze that are commonly referred to as the drain sponges. So, wound drains should be patent. You prepare to assist the removal of drains as prescribed by the surgeon when the drainage amount becomes insignificant. An abdominal binder may also be prescribed for obese and debilitated individuals to prevent dehiscence of the incision. On fluid and electrolyte imbalance, you need to monitor the IV fluid administration as prescribed, and you record the input and output. Also, you need to monitor for the signs or fluid or electrolyte imbalance. You need to monitor the intake and output of the nausea and vomiting. You maintain patterns of the nasogastric tube if present, and monitor for the placement and drainage per the facility's policy. You also monitor for abdominal distension, monitor for passage of flutters or return of bowel sounds, administer frequent oral care at least every 2 hours. You also need to maintain the NPO status until the gag reflex and peristalsis return. Also, when oral fluids are permitted, you start with ice chips and then water. Ensure that the patient advances to clean liquids, then to regular diet as prescribed, as the client can tolerate. Remember, you need to prevent aspiration by turning the patient to side lying position if the vomiting occurs. Make sure you have the sanctioning equipment available and ready to use. On the renal system, you need to assess the bladder for distension. You need to monitor the urine output. Remember, the urine output should be at least 30 mils per hour. If the client does not have the urinary catheter, the client is expected to void within 6 to 8 hours postoperatively, and this depends on the type of analgesia or anesthesia that was administered. Ensure that the amount is at least 200 mils. Okay? Correct, guys. What about the pain management? Here you need to assess the type of anesthetic drug and preoperative medication that the client received and note whether the client received any medications in the post-anesthesia period. As a nurse, you need to assess for pain and inquire about the type of location of pain. Ask the client to rate the pain on a scale of 1 to 10, with 10 being the most excruciating one. Okay, if the client is unable to rate the pain using the numerical pain scale, you need to use a descriptor scale that lists words that describe different levels of pain intensity, such as no pain, mild pain, moderate pain, and severe pain, or other available pain rating scales. You need to monitor for objective data related to pain, such as facial expressions, body gestures, increased pulse rate, increased blood pressure, and increased respiration. We inquire about the effectiveness of this last pain medication and then administer this pain medication as prescribed by the physician. Ensure that the patient with these patient control analgesia pumps understand how to use it. If the patient has been given an opioid, you administer it and assess the patient after every 30 minutes for the respiratory rate and the pain relief. Use non-invasive measures to relieve postoperative pain, and these measures could include the provision of the distraction, relaxation techniques, guided imagery, comfort measures, positioning, back rubs, a quiet and restful environment. Make sure you document the effectiveness of the pain medication and the non-invasive procedure. Test point, you need to consider the cultural practices and beliefs when planning pain medication. Culture really influences how people respond and perceive pain. Okay? In terms of the complications that you have to really prevent, we have the notorious one being a pneumonia and atelectasis. Remember, pneumonia is this inflammation of the alveoli that's normally caused by infectious process. It may develop between 3 to 5 days postoperatively, and this normally results from either infection, aspiration, or immobility. While atelectasis, on the other hand, refers to a collapsed or a airless state of the lung that may result from airway obstruction caused by accumulated secretion or failure of the patient to deep breathe or ambulate after surgery. Okay, this atelectasis is normally a postoperative complication that usually develops between 1 to 2 days after surgery. So on assessment, you need to look at and find out if there is dyspnea or increased respiratory rate. As a nurse, you need to auscultate to find out if there are crackles over the lung area, and also take the temperature to see if it's elevated, and find out if the patient is having productive cough and chest pain. Intervention, you will be assessing the lung sounds. You need to reposition the client after every 1 to 2 hours. Encourage this patient to deep breathe, to cough, and use incentive spirometry as prescribed. Also provide chest physiotherapy and postural drainage as prescribed. You also need to encourage this fluid intake and early ambulation. And lastly, use suction to clear these secretions if the client is unable to cough. Another complication is hypoxemia. And hypoxemia refers to inadequate concentration of oxygen in arterial blood in a post-operative client. So this hypoxemia can be due to shallow breathing from the effects of anesthesia or medication. So the nurse should find out or assess to find if the patient is demonstrating restlessness, dyspnea, diaphoresis, tachycardia, hypertension, cyanosis, and low oxygen oximetry readings. When intervening, you need to monitor for signs of hypoxemia. You also need to notify the surgeon, monitor the lung sounds and the pulse oximetry, administer oxygen as prescribed, encourage deep breathing and coughing, and use of incentive spirometry, turn and reposition the client frequently, and encourage ambulation for that matter. Another complication is the pulmonary embolism. And in pulmonary embolism, this is an embolus blocking the pulmonary artery and disrupting blood flow to one or more lobes of the lung. So assessment will include sudden dyspnea, sudden sharp pain or upper abdominal pain, cyanosis, tachycardia, and a drop in blood pressure. So you need to quickly notify the physician immediately because pulmonary embolism is life-threatening and requires emergency care plan. We have need to, or otherwise you also need to monitor the vital signs and also administer oxygen and other medication as prescribed. Hemorrhage is also another complication, and this refers to the loss of amount of blood externally and internally in a short time period. So the nurse needs to assess to find if the patient is demonstrating restlessness, if the patient is having weak and rapid pulse, if the patient is demonstrating signs of hypotension, tachycardia, cold, clammy skin, and reduced urine output. Remember, urine output should be at least 30 mils in 1 hour, okay? So you can intervene by providing pressure to the site of bleeding. You notify the physician, administer oxygen as prescribed, administer IV fluids and blood as prescribed. Prepare the client for surgical procedure if necessary. The other complication is shock, and shock, this is the loss of circulatory fluid volume, which usually is caused by hemorrhage. It's similar to the assessment findings of the hemorrhage. So if the patient is in shock develops, you have to elevate the legs, you notify the surgeon and determine the threat and the cause of the shock. You need to administer the oxygen as prescribed, monitor the levels of consciousness. You need to monitor the vital signs for the increased pulse or increased blood pressure. Monitor intake and outputs, okay? Then lastly, you can also look at the assessing the color, temperature, targa, and moisture of the skin and mucous membranes. You need to administer the IV fluids, blood, the colloid solutions as prescribed. Remember the test points. If the patient had a spinal anesthesia, you don't need to elevate the legs any higher than placing them on the pillow. Otherwise, the diaphragm muscles needed for effective breathing could be impaired, and this will not be okay for your patient. On thrombophlebitis, this is the inflammation of a vein accompanied by clot formation. So the veins in the legs are affected commonly because of the gravity, okay? So in assessment, you need to assess for vein inflammation, see if the patient is reporting any aching or cramping pain. The veins will feel hard and cord-like and will be tender to touch. The patient could be having elevated temperatures. So you need to monitor the legs for swelling, inflammation, pain, tenderness, venous distension, cyanosis. You notify the surgeon if these signs are present. You need to elevate the extremity 30 degrees, allowing no pressure on the popliteal area. Encourage the use of anti-embolism stockings as prescribed. You need to remove the stocking twice a day to wash and inspect the legs. Use sequential compression device as prescribed. Perform range of motion exercise every 2 hours if the patient is confined to bed rest. Also encourage early ambulation as prescribed. Do not allow the patient to dangle the legs. Okay, this could also exacerbate the problem. You instruct the client not to sit in one position for an extended period of time. Remember to administer anticoagulants such as heparin sodium or enoxaparin as prescribed. On urinary retention, which is an involuntary accumulation of urine in the blood as a result of loss of muscle tone. It could be caused by effect of anesthetics or opioid analgesics and appears like 6 to 8 hours after surgery. So the registered nurse needs to assess the patient's ability to void, find out if they are restless or experiencing diaphoresis, low abdominal pain, distended bladder, and higher hypertension. Okay. All right, guys. Let me just have something here. You also need to monitor for voiding. Okay. Assess for distended abdomen by palpating the bladder or scanning if indicated. You also need to encourage ambulation when prescribed, and then also encourage fluid intake unless contraindicated. You need to assist this patient to avoid by helping the client stand, also provide privacy. Also, you can also pour some warm water over the perineum or allow this patient to hear some running water. Sometimes this normally promotes the voiding. Conduct the surgeons and catheterize the patient as prescribed after all non-invasive techniques have been attempted. Another complication could be constipation, which is an abnormal infrequent passage of stool, and this happens when the client resumes the solid diet post-operatively. So we have failure to pass stool within 48 hours. So the nurse needs to assess the absence for bowel sounds, abdominal distension, anorexia, headache, and nausea. So in terms of intervention, you need to assess for the bowel sounds. You need to encourage these patients to have a fluid intake of around 3 liters per day, unless contraindicated. Encourage the patient's early ambulation and encourage consumption of fiber foods unless contraindicated. Also provide privacy and adequate time for bowel elimination. You need to administer stool softeners and laxative as prescribed. Paralytic ileus, and this is failure of appropriate forward movement and bowel contents. These conditions occurs as a result of this anesthetic medication or manipulation of the bowel during the surgical procedure. So the patient may be vomiting post-operatively. Patient may present with abdominal distension or absence bowel sounds and bowel movements. Okay. In terms of intervention, you need to monitor intake and output, maintain NPO status until the bowel sounds return. You also need to maintain patency of an nasogastric tube if it's in place, assess its patency, its drainage per the policy of your facility. Remember to encourage early ambulation, administer IV fluids or parental nutrition as prescribed. You need to administer medication as prescribed to increase gastrointestinal motility and secretions. If the ileus occur, it is treated fast, okay, non-surgically with bowel decompression by inserting this nasogastric tube attached to intermittent or constant suctioning. Remember, the test point is that when the patient is having vomiting post-operatively, or patient having abdominal distension and absence of bowel sound, this could be signs of paralytic ileus. Wound infection, and wound infections may be caused by poor aseptic technique or contaminated wound before surgical exploration. Also, existing client conditions such as diabetes or immunosuppressive may also place this patient at risk of developing these wound infections. Wound infections usually occurs between 3 to 6 days after surgery, so we could have purulent material may exit from the drains or separated wound edges. The patient may present with fever and chills, could be also be warm, tender, painful, and inflamed incision site. Skin could be edematous at the incision and tight skin switches. Patient could also be having elevated white blood cells on the CBC report. The intervention, you need to monitor the temperature. Also, you need to monitor the incision site for approximation of the suture line, edema or bleeding, and signs of infections, which are normally abbreviated as RIDA, redness, erythema, ecchymosis, drainage, approximation of the wound drainage. You need to notify the surgeon if the signs of wound infections are present. Make sure to maintain patency of the drains and assess drainage amount, color, and consistency. You maintain sepsis, change the dressing, and perform wound drainage if prescribed. Remember to administer the antibiotics which have been prescribed for your patient. In terms of wound eviscerations and dehiscence, find that wound dehiscence is normally the separation of the edges at the suture line. It usually occurs between 6 to 8 days after the surgery. while wound evisceration is the protrusion of the internal organs through that incision. So, and this also occurs within the 6 to 8 days after surgery. Evisceration, we have to know that is the most common among obese patients and clients who have had abdominal surgery or those who have poor wound healing ability. And remember, it is an emergency. Wound eviscerations is an emergency. So the surgeon has to be notified in the shortest time possible. You also need to assess, and when assessing the HIS-sense, that is the separation of wound edges at the suture line, the patient could present with increased drainage, opened wound edges, and appearance of underlying tissues through the wound. Whereas on evisceration, we'll have discharge of serosanguinous fluid from the previous dry wound and appearance of loops of bowel or other abdominal contents through the wound. The client could report a feeling of popping sensation after coughing or turning. Okay, popping sounds. So wound evisceration, you need to call for help. Ask the surgeon to be notified and that needed supplies need to be brought to the client's room. Remember, as an RN, you have to stay with your client. While waiting for the supplies to arrive, you need to place the patient in low Fowler's position with the knees bent. Okay, you cover that wound with a sterile normal saline dressing and you keep the dressing moist. Remember to take the vital signs and monitor the clients closely for any signs of shock. Prepare this patient for possible surgery and then document the occurrence and action taken and the client's response. We also have the ambulatory care or 1 day care, okay, day care, stay surgical units. The criteria for this client's discharge for these day cases, you have to ask yourself if the patient is alert and oriented. That's okay. Has voided. That's still okay. The patient has no respiratory distress. The patient should be able to ambulate, swallow, and cough. The patient should have minimal pain. The patient should not be vomiting. The patient should have minimal, if any, bleeding from the incision site and the patient should be having a responsible adult available to drive the client home and the surgeon has signed a release form, then the patient is free to leave. Remember, on the discharge teaching, you need to discharge teaching should be performed before the date of the scheduled procedure. You need to provide written instruction to the client and family regarding the specifics of this care. Instruct the client and the family about postoperative complication that can occur, and then provide appropriate resources to the patient care. You need to instruct the patient not to drive or make important decisions or sign any legal documents within 24 hours after receiving general anesthesia. Okay, you have to instruct the client to call the surgeons or ambulatory center or the emergency department if post-operative problems occur. You have to instruct the client to keep the follow-up appointments with the surgeon. Okay. You also need to assess the patient's readiness to learn, education level, and desired change to modify lifestyle. Remember, you have to assess the need for resources needed for home care, demonstrate care for the incision, and how to change the dressing. You also need to instruct the client to cover the incision with plastic if showering is allowed. You also have to ensure that the client is provided with 48-hour supply of dressing for the home use. Instruct the client on the importance of returning to the surgeon's office for follow-up. Instruct the client that sutures usually are removed in the surgeon office and this should be within 7 to 10 days after surgery if they have demonstrated healing. Inform the client that staples are removed 7 to 14 days after surgery and that the skin may become slightly reddened when staples are removed or ready to be removed. You need to talk about the sterile adhesive strips, that is the steri strips. This one may be applied to provide extra support after the sutures are removed. You need to instruct the client on the use of medication, their purpose, dosages, administration, side effects, or adverse effects. You need to instruct the client on diets and drink 6 to 8 glasses of fluid per day. That's approximately 3,000 mils or 3 liters per day, unless there's a contraindication. You also need to instruct the client about the activity levels and to resume normal activities gradually. You instruct the client to avoid lifting for like 6 weeks if major surgical procedure is performed. Remember, if they do this, this could be complicate into dehiscence and evisceration, which is an emergency. You need to instruct the client with an abdominal incision not to lift anything weighing 10 pounds or more, or not to engage in any activities that involve pushing or pulling. Remember to convert pounds into kilograms. You say 2.2 pounds will make 1 kg. Okay? Okay, great, guys. The client usually can return to work in 6 to 8 weeks depending on the procedure as prescribed by the surgeon. But to instruct the client about the signs and symptoms of complication, when to call the surgeons. Okay. Others, guys, thank you so much for your time. We were looking at the perioperative care nursing. We hope this presentation has been helpful to you. Okay. Okay, and interactive. Okay, guy, we wish you well, and we hope to meet you again. Take care.